Good afternoon, everyone. My name is Yanela Barrios. Welcome to Forum 4 of Week 5. Today I'll be talking about polypharmacologic, nutritional, and pain concerns based on Chapter 6, 13, and 4 of our study book. Okay, so the chapters that we're gonna cover today are Chapter 13, the older adult who is frail, Chapter 4, Psychosocial Aspects of Aging, and Chapter 6, Geriatric Pharmacology. On Chapter 13, the older adult who is frail, the authors state that PTs should always understand and recognize frailty so they can understand age-related diseases. They also describe frailty as a biologic syndrome of decreased reserve and resistance to stressors, resulting from cumulative declines across multiple psychological systems, which causes vulnerability to adverse outcomes. Some of the attributes that they mention that will be helpful to recognize frailty are weakness, slowness, shrinking, low energy, and inactivity. In order to classify individuals as not frail, pre-frail, or frail, the authors include some models of frailty. One of those is the Phenotype of Frailty by Linda Fried and others, which consists of 5 clinical attributes. Basically, the way it works is if the individual has 0 characteristics out of those 5, it will be considered not frail. If the individual has 1 or 2 characteristics, it will be considered pre-frail, or it will be considered frail if the individual has 3 or more characteristics of those 5. They also include some domains of frailty. The most common ones are the physical domains, which include nutrition, mobility, physical activity, strength, endurance, and balance. But other domains to be considered in frailty are cognitive, psychosocial, and social domains. They also discussed frailty transitions, where they stated that the state of frailty is actually dynamic. It's not static, so it's always changing. And when it occurs, it usually happens to be to greater states of frailty. Now, transitions to lesser degrees are also possible, but they are most likely to be from pre-frail to not frail. And the most common transition is from non-frail to pre-frail and from frail to death. As mentioned before, there are multiple tools that you can use in order to complete an assessment of frailty. Some of them include Comprehensive Geriatric Assessment, PRISMA-7, Clinical Frailty Scale, Phenotype of Frailty, Frail, Gait Speed, and Life Space Assessment. Frailty could be prevented, and there are 2 different types of prevention. The primary prevention includes promotion of physical activity, cognitive stimulation, exercise and healthy diet, cessation of smoking, promoting emotional recovery, engaging in an active and socially integrated lifestyle, an ideal amount of sleep, maintenance of proper body weight, and metabolic control. The secondary prevention includes drug treatment for chronic diseases, fall prevention interventions, and exercise and nutritional support, as well as social and psychosocial support. Some of the intervention methods to manage frailty include physical activity and exercise, nutrition, medication, hormonal management, and self-management programs. Some other aspects to consider in frailty are implication of frailty, pathophysiology of frailty, and frailty and sarcopenia. Chapter 4, psychosocial aspect of aging addresses several psychosocial considerations for aging adults that can inform the therapist about the psychosocial context of the individual. Some of these considerations include successful aging, motivation and engagement, life transition, gender and sexual identity, sex and intimacy, spirituality, trauma-informed care, and mental conditions. Successful aging definition has been addressed actually since 1916, according to the study book, and it's based on different theories and perspectives, but one of the most complete definitions refers to successful aging as the capacity to function across many domains. This includes physical, functional, cognitive, emotional, social, and spiritual, and it's to one's satisfaction, and it can be predisposed by cultural influences, personality, resilience, wisdom, loss, loneliness, and grief. PTs should also contemplate motivation and engagement because motivation is key for success of any physical therapy intervention. Lack of engagement can affect outcomes and reimbursement. Older adults' motivation to perform activities are influenced by personalization, social support, patient-centered goals, and personality. Life transition aspects. Transitions occur when the individuals adopt and adjust to a new lifestyle role, such as retirement, loss of job, from parent to grandparent, or a relocation. Another psychosocial aspects to be considered by PTs are sex and intimacy, gender and sexual identity, spirituality, trauma-informed care, and mental health conditions such as depression, anxiety, bipolar disorders, and suicide. Chapter 6. Geriatric Pharmacology. In this chapter, it is discussed how drug therapy can affect older individuals receiving physical therapy by describing the pharmacologic profile of the geriatric patients, focusing on why adverse drug reactions, ADRs, tend to occur more commonly in older adults. They also describe the most common ADRs in older adults, the beneficial and adverse effects of specific medications, and how these medications can have impact on the rehabilitation of these individuals. The increased incidence of ADRs in older adults are influenced by two principal factors. The first one is patterns of drug use, and the second one is altered response to drug therapy. About patterns of drug use, we know that adults older than age 65 years compose about 15% of the U.S. population, but they purchase over 30% of all prescription drugs. We also know that approximately 36% of older adults age 65 and older living in the U.S. take at least 5 different medications. Additional factors in geriatric pharmacology is the use of over-the-counter products and nutritional supplements, which brings to the table the definition of polypharmacy, which is the excessive or inappropriate use of medications. Older adults are often at a high risk for polypharmacy. And about altered response to drug therapy, we know that alterations in drug response in older adults can be attributed to differences in the way the body handles the drug, which is known as pharmacokinetic changes, as well as the differences in the way the drug affects the body, which is known as pharmacodynamic changes. Other factors that increase the risk of ADRs include the presence of multiple disease states, lack of proper drug testing and regulation, problem with patient education and not adherence to drug therapy, or the use of inappropriate medications. Some examples of the most common ADRs in older adults are gastrointestinal symptoms, sedation, confusion, depression, orthostatic hypotension, fatigue and weakness, dizziness and falls, anticholinergic effects, and extrapyramidal symptoms. The author also mentioned some general strategies to coordinate physical therapy with drug treatment in older adults. Some of these strategies include distinguishing drug effects from symptoms, scheduling physical therapy sessions around dosage schedule, promoting synergistic effect of physical therapy procedures with drug therapy, avoiding potentially harmful interactions between physical therapy and drug effects, education and compliance with drug therapy in older adults, and facilitating medication discussion with physicians. The pharmacologic aspects in geriatric patients caught my attention because, as we notice, this can become a problem if it is not properly addressed. So I went ahead and checked a few articles to find more information about the pharmacologic aspects in geriatric patients, and some of my findings were the following. In one article, I found that there is very little high-quality evidence to guide prescription for older adults, which could be the reason why there is still a lot of inconsistency in the way this should be managed. I also found that the use of at least one prescription medication increased from 84.1% in 2005 and 2006 to 87.7% in 2010 and 2011. Also, hospital admissions related to ADRs have increased over the past 20 years, particularly among patients above the age of 80 years. No drug has been consistently shown to prevent functional decline in humans. However, animal studies suggest that the supplementation with resveratrol is associated with improved functional performance in old age. About polypharmacy, I found that it is linked with several adverse outcomes like increased risk of ADRs, medication adherence, hospitalization, emergency room visits, falls and/or fractures, and a lower self-reported health scores. It is also linked to the increases in healthcare costs and adverse drug events, often leading to increased morbidity. The likelihood of older adults receiving prescription from multiple providers compounds also a risk of polypharmacy. And last but not least, non-prescription medication use, excluding herbal and complementary agents, should also be accounted for when considering the number of medications that are going to be prescribed to an older adult.